if there is. If you want to turn your camera off, if that's the case, please feel free to do that. Okay, Chloe. Good evening. Thank you very much for attending this event. This is my name is Graham Parsons. I'm Chief Pharmacist for Turning Point, and tonight we're going to be talking about the new service, which drug and alcohol service, which is opening on April the 1st through Turning Point. We're really excited about it. As I say, we had a site visit yesterday, and everything's starting to come together. So really looking forward to working with you all in Herefordshire. I'm just going to introduce the Turning Point team and also some of our key partners who are working with us. I will ask you to introduce yourself, so I'll introduce you, and if you can just give a couple of lines, couple of paragraphs. Martin, would you like to introduce yourself first?
Well, yeah, hi, thanks, Graham. Hello, everybody. So my name is Martin Hull. I am Clinical Director for Turning Point. So doctor. I also work a little bit in Birmingham, so not too far away from you guys, as a GP.
Thank you very much. Over to you, Catherine.
I'm Catherine Watkinson. I am the Acting Head of Medicines Management and Pharmacy at Turning Point, and I'm a pharmacy technician.
Thank you very much. So over to you, Hemang.
Hello, my name is Hemang Patel. I'm going to be supporting with the implementation manager's role within Hereford. So yeah, I'll be sort of supporting with the scripting and data side and day-to-day service of running.
Lovely. Thank you, Hemang. Chloe?
Hi, I'm Chloe. I'm the pharmacy technician here at Turning Point.
Lovely. Thank you very much. Owen?
Yeah, hi, good evening all. I'm Owen Bolger. I'm Turning Point's Head of Operations. I was responsible for the model design for the new Herefordshire contract, and I'm leading on the implementation.
Lovely. Thank you very much. And I'll just go to our external partners now. Andrea?
Hi, good evening, everybody. I'm Andrea Mulligan. I'm the UK Harm Reduction Manager for Vernicare. We are going to be supplying your needle exchange, pick and mix, paraphernalia, packs, etc. So I've been with Vernicare for over 5.5 years, and prior to that I was 17 years working directly in drug and alcohol services, so come with a wealth of experience to support you guys.
Lovely, thanks Andrea. And over to you, Stephen.
Hi, my name is Steve Parkinson from Neo 360. We work in partnership with Turning Point, providing the data collection systems that logs the transactions for needle exchange, supervised consumption, and also provides the financial element so that you guys can get paid on time and accurately.
Lovely. That's great. Thank you very much. So I'm just going to share my screen now and pop my PowerPoint up. Okay, hopefully you can all see that. So what we're going to be covering tonight, so we're going to be giving you a quick introduction to Turning Point, because some of you will be familiar with Turning Point, others won't. So we just want to set the scene in terms of our organisation. I'm then going to talk about substance misuse services. So Martin is briefly going to talk about his role. Appreciate there's no GPs on the call tonight, I don't think. Please raise your hand if there is. But Martin's going to talk.
I think we've got a couple.
Oh, tremendous. I
can see Simon Linane there.
Great stuff. So Martin's just going to talk about briefly about the GP, about the work with GPs, and hopefully how we can get involved with primary care and look for how we can deliver services and a better service for our clients as we move forward. I'm going to talk about pharmacy services. Then Andrea's going to talk about the needle and syringe provision and program. Stephen's then going to talk about the locally commissioned. Stephen's going to talk about Neo 360. We're going to talk about the locally commissioned service agreement, and then we'll have the opportunity at the end for questions. So over to you now, Owen. I'm just going to bring up the slide for Turning Point, and if you want to just talk through Turning Point, that'd be great.
Yeah, sure. Hi all. Good evening. So Turning Point, we've been around for over 50 years now. We are a not-for-profit, we're a charity, so 100% of our the money that we collect from local authorities and things like that goes straight back into delivering services. We've got quite a broad portfolio across the country of substance misuse services, mental health treatment, learning disability, primary care and employment. So we do have a lot of kind of cross-sector and holistic experience of delivering services, which we're going to be bringing to the Herefordshire area. We've 94%, as it says there, of our services are rated as good or outstanding by the CQC, and I think it's about 70% of the outstanding substance misuse services in the country are currently delivered by Turning Point. So we come with a really good pedigree in terms of our governance and our safety as well. You can see here on the slide on the right hand side just some of our overarching numbers, but I think in terms of the Herefordshire contract in particular, we've got about 28 staff at full establishment. We're going to be bringing over 24 staff are coming over on the 1st of April. We've got a couple of vacancies which we're looking to fill. We've currently got about 700 people in treatment with us, 700 clients or service users, patients, and we, on average, I think we're getting about 30 referrals per month. So it's quite a busy service, actually, given the size of the staffing team. So we're operating at about 70 service users per recovery worker, which is about the industry average at the minute. I think we'll do some more work with you guys on the data and the numbers as we kind of progress in the contract. But we're seeing a lot of throughput around alcohol numbers in particular, a relatively stable opiate cohort. You know, there's some new opiate clients are coming through, but not many, but a big numbers of referrals, of alcohol numbers. Some of our kind of methodology of our approach in Herefordshire is around partnerships, really. It's around a whole Herefordshire approach. I don't have to tell you how challenging the geography can be, but we've made a commitment in the tender to deliver services out in the communities, covering places obviously like Leominster and Ross and Ledbury, but also looking to go out to Bromyard and other places as well, as you know, as the COVID kind of roadmap allows us to ease things a little bit more. We obviously want to have lots of open communication and dialogue channels with you guys as our partners, and you know, we're really looking forward to working with you over the coming 5 years.
Lovely. Thank you very much, Owen. That was a comprehensive review of where we are, and also looking at where I suppose the start of our journey in Herefordshire, and yeah, it'll be really interesting to see how that develops. So now I'm going to introduce you to Dr. Martin Hull. I'm going to put the next slide up, Martin, which is about the referral system, but I expect you just want to talk a bit generally first of all about, I suppose, the role for primary care and GP engagement. So over to you.
Yeah, brilliant. Yeah, thanks, Graham. Yeah, so I mean, like all services, I think that the one of the key components to our success is going to be, as Owen mentioned, working with local colleagues and working with local GPs is always imperative. It's imperative through the implementation period, I guess, particularly, but also going forward as we try and build. And so we will definitely be wanting to foster some good lines of communication as early as possible with GPs. So I'm glad. I was told there was no GPs coming this evening, so I'm pleased to know that there are a couple. That's great. What I might suggest actually is, once we've got through the initial bit, before Graham spends quite a bit of detailed time talking about some of the ins and outs of the pharmacy contracts, is if the GPs would like. Owen, are we able to set up a breakout room type thing? Is that in your IT gift?
I can figure that out, definitely.
Because I think it might be useful then, because I can have a little chat to the GPs that are on the call. I don't think it'll take too long, just to kind of gauge their opinion about where we're at and what they would like, because that sort of thing, certainly when we've implemented services previously, has been really, really useful for us. We're really keen on ensuring that communication lines are open from the outset. Two-way communication, really. So the ability for our primary care colleagues to be able to refer patients in, or to have a clean line of communication for asking advice from our clinicians in Herefordshire, and also for us to be able to ensure that we're communicating effectively with primary care colleagues. That's really important, and the time when sometimes it's a bit glitchy is right at the start of an implementation. So just to reassure you, we are on top of this, and so certainly Owen, who will be overseeing the implementation, and Graham, who will be on site, and in fact a lot of the senior clinicians from Turning Point are going to be around in the first few weeks of the contract. We'll make sure that we're available for referrals and for advice, and to make sure it goes as seamlessly as possible. And then, and I think I'll come to the referral process in a bit, but then we want then to see where we go as far as joint working with primary care colleagues. There isn't a shared care system set up at the moment in Herefordshire. If you know what that means, that effectively is the term used for primary care-based drug treatment, so usually opiate prescribing. Most of our services do have shared care, some very long established and successful shared care services. We really like shared care. We, as an organisation, really recognise the advantages of kind of functioning and successful shared care service, as far as managing co-occurring conditions and enabling some, I was going to use the fairly old-fashioned term of hard to reach, but some of our service users who are hard to reach geographically sometimes, and sometimes for other reasons, are more engaged or have better access to their GPs. And so we really like the model of that. And that's something which I think once we've got our feet under the table, we might be talking to our local GPs about whether there's an appetite for, and what we could do to support shared care. Before that, and in the sort of first throes of the contract, if you like, it's just really all about engagement and ensuring that we're able to be as open and accessible as possible to our GP colleagues. And then it's about things like training and CPD, and how we can link into your local networks and make sure that we're as visible, I guess, as possible. Because if nothing else, our substance using service users are ones that use primary care a lot as well, aren't they? They're ones who, alcohol, frequent flyers through primary care and secondary care, and also with other substances. And so we will hopefully be working very closely. Do you want me to talk through the referral process? Is that one for you, Owen?
Yeah, I'm happy to take that one. We've had a question in the chat, and everyone, please just put your questions in the chat, and then as we get to natural breaks, I can call them out for you. Charlotte, I don't know if you want to ask your question or if you would like me to read it out.
Yeah, no, I'm happy to ask it. It's basically because I work in Wye Valley Trust as the hepatology nurse, and we're also going to be having a alcohol liaison nurse starting very soon with us in the trust. And so really it's all about how we would refer to you as well as an acute trust. Would it be the same system, or would you want to change that?
Yep, I think I can take that one. So I think we've met one of your colleagues. We've met with one of your colleagues during our model design phase, and we've actually put within our staffing structure a complex caseworker who will be responsible for, I think they're going to come to some of the MDTs which are being set up as part of that frequent attenders and hospital discharges panel. So we've got a dedicated team member that will be doing in-reach into the hospital, and that we're looking at once a week. But will also be a named person for there to be links at discharge, and we're just really looking to build those relationships for those that are kind of more complex, and to make sure that we've got really clear and quick referral routes for all the patients, really.
Owen, if I can come in there as well, we're always also talking to Sue Eldred from the who I'm sure you're aware of. We're starting active involvement with the ODN, and looking at ways in which we can improve the hepatology service from the organisation. So, for example, we're looking about being available to have DAA distribution from our service site as well, and we're working actively with the pharmacies as well, or with the LPC currently, especially as we move out of COVID, to look how perhaps pharmacies can get involved with the advanced service for Hep C testing. So we've started that process of reaching out. So I'm sure we will continue that.
Okay, great. That's really helpful. And I think, Graham, I'm going to give you a ring tomorrow on behalf of Sue, actually, about talking about that a bit further.
Right. You're the other person on the on the answer phone. Oh, right. Yeah. That'll be fantastic, because my understanding is there's already a lot of good work going on in Herefordshire around the Hep C agenda, but that doesn't mean that we can't kind of get over that finishing line with some of the other pieces of work which I know you and Sue are keen to put in place.
Yeah, no, that sounds great. Thank you.
Lovely, thank you.
And it was Dr. Milestone that we'd been speaking to previously to agree that that pathway.
Okay, that's perfect. Thank you.
Lovely, thank you.
So in terms of our approach to referrals, really, we're trying to make as many routes there as possible. We're not having drop-ins at the minute. I'm sure that not many people on the call will be from a COVID point of view, but that will be an offer once we follow the roadmap. At the minute, from the 1st of April, you're going to be able to contact us via the telephone, and one of our reception team will be able to take a referral over the phone. We also will be accepting referrals via email or letter, and we will have an nhs.net email address, which we'll share with you from Go Live. The newsletter will be going out tomorrow, I think. And then a very straightforward way for referrals to take place, both from on an individual basis and from a professional basis, will be through our website. So you just go onto our website. I'll share the link again. You click refer, and then this kind of the bottom half of the slide that you can see now pops up. You go through, it's 4 or 5 screens of a similar size to the one you can see there, with the kind of the basic information. There's a little bit of an audit C on there, and then we'll make contact with the service user.
Lovely, thank you very
and
much.
Also, sorry, and to clarify, service users can also self-refer as well, can't they, in that process?
Oh, totally. Yeah, the service users can also use any of those routes. Yeah.
Lovely, thank you very much. I mean, just for information, because I know, thanks for picking up that question, Owen. I've got my full screen up, so I can't see if hands go up. So if Catherine or Chloe could just indicate if there is, and Owen, if you can actively be involved in that as well, that will be fantastic. So that's great. Thank you very much, Martin and Owen. In terms of the breakout rooms, like I say, I will crack on. I don't know if somebody can manage that while we go along. If not, perhaps we can we might be able to set that up separately. So I will let you work on that in the background. Okay, so I'm going to go on to the pharmacy work now. So I will try to limit the stuff that I'm going to deliver, because it would be good to. I want to spend a bit of time with Andrea and Stephen, so they can go through the NSP, the needle and syringe program information, and also the Neo 360 information, just to give you some assurance and information around how that system works. So I'm going to talk about supervised consumption first of all. Pharmacies on the call and the GPs will be familiar with supervised consumption. It's recommended by NICE, and it's recommended within the clinical guidelines, and that's the most recent clinical guidelines from 2017. It ensures the client receives their prescribed dose correctly, reduces diversion, provides an opportunity for regular assessment on compliance and general health and well-being through the pharmacy, and gives us the opportunity to have that two-way engagement as well. It builds that therapeutic relationship with the pharmacy and promotes harm reduction, both through the provision of OST and the provision of needle and syringe program paraphernalia if needed. And it reduces the risk of drug-related deaths. So we have good evidence that methadone, for example, deaths are reduced fourfold following its introduction in England and Wales. So we know that there's evidence for it, and we support that. And how we decide on supervision is the levels are based on individual assessment, as it is with any service. I mean, there's some givens. For example, if clients are new to service, starting off on a prescription, inevitably they will be on supervised consumption. That restriction was changed slightly during the first pandemic wave, when there was suggestions from PHE that there could be the relaxation of supervised consumption even for those clients. But in general, our individual risk assessment will include that. And most service users will still have a TTA dose on a Sunday. So again, what I would ask my pharmacy colleagues to discuss is to make sure that even if somebody is on a supervised consumption dose Monday to Saturday, that you do talk about the issues around safe storage, because 5 ml of methadone can kill a toddler. So we need to be mindful of the potency actually of the long-acting opioid methadone. So at the start of the intervention, and I don't know what happens now, but this is how we will do it. You will get a call from Turning Point, from a recovery worker, a prescriber, whoever, to confirm the start of the intervention. So we make it quite clear in our policies that if somebody is new to treatment, new to a pharmacy, we will give you a call to actually inform you, and also to have a discussion on the availability of supervised consumptions within your pharmacy. We've obviously sent the expressions of interest out, and we're getting information at the moment about pharmacies that want to engage with it, with ourselves. We're taking the baseline position that if we don't hear from you, we will continue with the services that are currently there, but we will be contacting you more robustly to confirm what the arrangements are as we move forward. We also have a confirmatory ID letter, which we can send with a client if the client has no ID. And I know this can sometimes be an issue with pharmacy, with many clients that don't have formal ID, which puts you in a position when you're actually dispensing a CD Schedule 2. So we have a letter which we can provide to clients. Please ensure your clients know the opening times. Again, our service will have a list of the pharmacies providing supervised consumption and opening times and information. And we will provide a three-way agreement. So we talked to the LPC about that, and the general consensus was that you would prefer clients to have a three-way agreement, which actually outlines certain situations and things like opening times and expected behaviour within the pharmacy. So we will have those available. Space for supervision. Again, this often provides a bit of debate. Obviously, with your pharmacies, the majority of pharmacies have consultation rooms now. Consultation rooms are available for clients to have supervised consumption, but we've always been of the mind that this is something you should discuss with the client, because some clients actually feel stigmatized by being taken to a room for supervision. So please, talk to the clients, agree with them in terms of the privacy and the confidential nature and how they want their supervision to be done within the pharmacy. And explain the process for supervision, including missed dose procedures, and we'll talk about that. We'll talk about that in a moment. Again, this is basic stuff, so I'm not going to go through this. This is all included in the service level agreement as well. And in terms of Espranor, I know you're using Espranor in Herefordshire at the moment, so you are familiar with it. Obviously, the difference between Espranor and generic buprenorphine is Espranor actually dissolves on the tongue rather than under the tongue. Personally, I'm a fan of Espranor. There's a number of reasons which we switched, and yes, the major reason was the increase in generic prices of methadone, but certainly the information that we're getting from our clients and the pharmacies where we work with Espranor is it's a lot easier to supervise. It dissolves quicker, and that is something that is supported by both the clients and the stakeholders who we're working with. In terms of missed doses, so this is a chart that an appendix which has gone out with the locally commissioned service agreement as well. We ask, as per the Medicines Ethics and Practice Guidelines, that if service users miss 3 consecutive days, that you actually hold the prescription and contact the service prior to dispensing it. And again, we outline within that, it's important for pharmacies to understand that, it doesn't, if you are holding the prescription, it doesn't mean that the prescription legally stops and you need a new prescription. If you get a confirmation from a prescriber that it is okay to continue with it, we can continue with that one. We would also ask you that if a service user is missing 4 non-consecutive days off a prescription, particularly if there's a pattern, so if they're missing every Monday, every Wednesday or whatever, obviously, we would hope that you will have that rapport with the client to discuss why that might be, but we'd also like to have a conversation around that so we can try and explore with the client the reasons for that and maybe put something in place that would encourage them to attend on both days. Again, we don't need you to contact us if the client misses 1 day, apart from during titration. One of the concerns, obviously, is if you're doing a titration and the client misses it during that time, we may have a larger increase in dose compared to if they were on a maintenance dose. So it's important that it's someone during titration, if they're missing doses, you just give us a quick call and let us know what's going on. We will, when the frequently asked questions document comes out in the next couple of days, we will have our information in there, our telephone number. The telephone number comes straight through to our service, so you will get somebody on the end of the phone from our service. So other considerations, so there is training and accreditation associated with it. What we would want pharmacists to do, the lead pharmacist in the pharmacy, our requirements are no different from most other organisations, is that you complete the CPPE module, the e-learning module. Again, we don't expect you to send the e-learning module in. We don't expect, and we won't be chasing it. We reserve the right to ask to see the CPPE module, but it's not something that we're going to be chasing. We're all professionals, and we would expect you to, to reach that standard. We'd also want you to complete the declaration of competence, and that's similar to any locally commissioned agreed service. So we would like you to complete that training and for you to do that self-declaration so that you have an understanding and you have the confidence that you can deliver these services within the Herefordshire area. Prescribed drugs will be methadone oral solution and Buprenorphine. Those are our two current formula drugs in terms of supervised consumption arrangements. And the fees at the moment, they're going to change. They're going to stay where they are. So we've agreed with the LPC that during the first 6 months, we're going to assess the pharmacy services across Herefordshire, get an understanding of what the needs for our clients are, what the needs for pharmacies are, and what the current spread of services are. And that will put us in a position after 6 months to decide how we move forward with that. Included in that calculation is obviously looking at extra services. I'm obviously a fan for developing services within primary care, whether that's GP practices or community pharmacies. And we want to look at areas like take-home naloxone, which is something that we've successfully launched in 5 areas during our tenure, and especially over COVID. And I'm also the hepatitis C lead for the organisation, or I will be till April the 1st. And I'm particularly interested in looking at the advanced service for Hep C testing again as we move out of the flu vaccination season. So yeah, I'm particularly interested to look at these areas too. Pharmacies will expect to have standard operating procedures as you would for anything. Again, it won't be our role or our job to actually assess those, but we would expect you to have those in place. And as I've said at the bottom, we're going to do a 6-monthly pharmacy needs assessment, looking at the substance misuse services during the first 6 months and our tenure within Herefordshire. I just want to talk about COVID-19 and the effects on supervised consumption, as I'm sure Herefordshire is no different, and levels have dropped off significantly. So we saw a very significant drop off in April last year. And that was partly due to advice from Public Health England, partly driven by the government guidance around social distancing, which saw us, I suppose, take a completely different step, which we would have previously, in putting clients on less frequent pickup, less collections, and virtually decimating supervised consumption. So part of it was driven by that, and part of it was the uncertainty in pharmacy land as well, and pharmacy colleagues. This was a new disease, a new condition, and obviously a lot of pharmacies were and their corporate organisations were concerned how they would manage that, especially with the inconsistencies with PPE at the start. So it was for a number of reasons that it dropped. We're now seeing a gentle increase, an incline in supervised consumption levels, and we would expect that to continue to increase as we move out of COVID and continually reassess our clients. In terms of that process, we will continue to review our clients against our risk assessment toolkit for supervised consumption and make the necessary changes. As we've said to other pharmacies in other areas, we welcome your feedback around clients, around concerns, around any issues that you may have. If you want to talk to us about them, you're more than happy to pick up the phone to speak to one of our recovery workers or one of our prescribers, because we would like that two-way conversation. So that's supervised consumption. So again, I can't see hands. So have we got any questions in terms of supervised consumption within Herefordshire?
There's nothing in the chat at the minute, but I don't know if anybody's got any points they'd just like to raise on this element of the presentation.
I've got one question which might be useful for everyone to just understand how you go through these reviews and how you decide who goes on methadone, who goes on buprenorphine, and how the doses go up and down and that sort of thing.
Oh, that's a whole lead. Who is that? Sorry, can you introduce yourself?
That's Fiona.
I thought it was Fiona.
I know it's a big thing, but actually that's quite important for even if we just sort of some sort of comment on how the review is going through with the clients, because obviously we've seen the changes due to COVID.
So in terms of the review, I'll do the review on supervised consumption and TTA first of all. I mean, we have a set template which we use to assess. And it will be based, there's a lot of elements with it. I mean, obviously it's based on the stability of the client, and that comes in a number of ways. Obviously testing has been limited during COVID, but we'll look at on-top use, we'll look at self-reported on-top use, information from screens that we have. We'll also look at engagement from the client. We'll look at whether they're in work or whether they're in training. In terms of the drug use, we'll see whether that drug use is intermittent drug use, oral drug use, or whether that's regular injecting drug use, which would present as more of a concern. We'll also look at whether it's polydrug use, because polydrug use, polysubstance use, including alcohol, gives us more cause for concern in deciding how we manage, how we calculate whether clients will have take-home dose or supervised consumption. Other areas will be mental health presentation, physical health. So have they got a mental health presentation which lends them towards the increased risk of self-harm? So we'll look at self-harm history associated with that. In terms of physical health, that will include things such as mobility. And one thing that that becomes more prominent in a rural area is, along with that risk calculation, we have to look at where clients are. And in terms of their availability for community pharmacies. So you will sometimes see a smaller level of supervised consumption in rural localities, not in all rural localities, but in some. We'll also look at whether the client has children at home, whether there's any safeguarding issues, both in terms of adult safeguarding and child safeguarding. So both those elements need to come into place. And also whether the client has stable accommodation. Obviously, if a client is homeless, the ability to have a large takeaway dose is very limited. So that client will more as likely be on a daily supervised consumption dose, because not only is there a risk to themselves by having it on the streets in terms of their vulnerability, but there also may be a risk for others, because obviously if it's lost on the street, that can increase the risk of somebody having an accidental overdose from the medication. So that's really the decisions around supervised consumption and TTA. Martin, have I missed anything that you want to add to that?
No, I mean that's most of it, isn't it? It's. I think I probably wouldn't have been quite so detailed. I probably would have said it's a variety of clinical and safety reasons that dictate the decision. But no, Graham, you've passed your Viva. Well done. It's good.
It's the pharmacist coming out in me, Martin.
We like to know everything. You see, this is what it is.
Yeah, I mean, in terms of methadone and buprenorphine, there's some good guidance in the Orange Book which I can share, and also with NICE. Methadone remains the most common intervention, about 75 to 80% on methadone, 20% on buprenorphine. They're both different beasts. You know, you take enough buprenorphine to a blocking dose, and it will block the effects of opioids. And some clients, you know, they're not ready for that. And also, you get with methadone is what one of the psychiatrists used to work with, a bit like psychic glue. You get that typical opioid effect, that kind of cotton woolly feeling, and sometimes for somebody that's had a significant trauma in their past, they welcome that, and they would not tend to go towards buprenorphine, which kind of opens the mind up further. But I'm more than happy to send more information out about that. So yeah, there you go, Fiona.
Yeah, that's helpful, thanks. And it was more really sort of thinking about what the pharmacist might pick up, and hence want to understand what the decision process has been behind the scenes. So that, if they pick up a change in behaviour, etc., or circumstance. Thank you.
We're more than happy to share. I'm more than happy to share our TTA assessment as well. So you can have a look at that and share that. And yeah.
Okay.
I think that thing, Fiona, that you just said is actually really nice to hear, because I think we're always in all of our services really keen on hearing, and obviously there's some things where pharmacists say, you have to tell us if they've gone 3 days without picking up things. We really like it when people tell us more, because it's just sometimes the softer intelligence is really, really valuable. So they've been really consistent at picking up, but they've just been a little bit less consistent lately, and we add that together with a few other things, and that might get our alarm bells ringing. So that sort of information we will always be amenable to listening to, definitely. And it works better in a smaller service like Hereford, where you can actually build a relationship with pharmacists and know, get that 2-layer communication going. It's invaluable, actually, I think. It's one of the reasons why I think shared care sometimes works really well as a GP who prescribes, because you often have 2 or 3 pharmacists who all of your patients go to, and so you do know them by name, and they phone you up and say, I've just seen John and he doesn't look quite right. And in a bigger service you sometimes lose that. So if we can promote that from the outset, that's really helpful for us and for the patients.
Yeah, I think it's something that we're quite keen to sort of look at how it fits in, because obviously over COVID we sort of became more aware of where patients and clients were handling it better than others, shall we say?
Yeah, and we've moved a little bit to a remote. We've moved quite a lot to a remote consulting model at the moment. We'll move back at some point, but probably not all the way back. We will almost certainly inculcate an element of remote consulting into our future systems. So it means that the face-to-face contact with pharmacists becomes even more important, actually, for that. So we would definitely need to ensure that you know how to get in touch with us easily, to let us know those bits of intelligence, definitely.
Yeah, and I know, Fiona, we've had separate conversations. I think there's a lot of that pharmacists can do and offer, and pharmacy staff. So hopefully we can explore that further as we move forward.
Yeah, lovely.
Lovely, thank you. So I'm going to needle and syringe programs now. So NICE Public Health Guidelines 52 presents the case for needle and syringe programs, and the main aim, just to clarify it, for needle exchange is to reduce the transmission of BBVs and other infections, which benefits individuals and wider society. So I'm mindful that obviously we've got one of the BBV nurses, hepatology nurses, with us, and I think I am a harm reductionalist. I think to have a client to work with, that client needs to be alive. So the first principle is to bring them in, engage them, reduce their risk, and work towards them becoming drug free. But it shouldn't be the initial aim. The initial aim should be engagement and reducing the risk of things like BBVs, and getting hepatitis B vaccinations and hepatitis C treatment when needed. And needle and syringe programs form a big part of this. And again, in Herefordshire, a big rural area, we have 5 pharmacies within the area, and it's certainly something that we're keen to look at, and to see whether we can increase the number of NSPs within the area, and look at additional services that can be provided through them, such as take-home naloxone. So if anybody's on the call that isn't an NSP, please get that expression of interest back with us if you're interested in NSP work, because we'd like to engage with you and talk to you about that. And it also engages clients with integrated services such as OST, opiate substitution treatment, naloxone, BBV testing, and Hep B vaccination. And there's good evidence that it reduces BBV rates, particularly in conjunction with OST programs. And even though it's not talked about a lot now, in terms of HIV, I mean, it's been I suppose, more in the public domain recently with the Channel 4 program, It's a Sin, which certainly with the older pharmacists takes us back to the days in the mid-80s when AIDS hit the scene. and we started to get the adverts for Don't Die of Ignorance. So and it was the time when pharmacies became really active in this area. And we know, looking at the international evidence, that countries that don't have structured NSPs in place have very high rates of HIV and very high rates of other BBVs. So it's about the harm reduction. It's about the reduction in related harm associated with drug use, especially injecting drug use. And it provides the opportunities for pharmacies to give harm reduction advice, such as safer injecting. And our plan will be during the first 6 months to offer a session on harm reduction and safer injecting to community pharmacists, and we'll be talking about that more with Fiona and the LPC.
Quick question, Graham, before you move off of this, you may be able to do it. Andrew's asked about whether pharmacy will be supporting IPED users, so steroids, peptide growth hormone, etc., as in having injecting equipment available for that cohort.
So at the moment, what we're going to be doing, we're looking at what We Are With You have been offering through community pharmacies, and we're matching that. What we will then do, we will look over the first 6 months. We will talk to service user groups. We will talk to pharmacies. We will talk to commissioners about what the need is. Because if there is a need for IPED provision, particularly if there's an area of Hereford or Herefordshire that might be linked to gyms, or there might be gyms close by where we feel that is needed, we'll certainly be looking at that, and if needed, we'll be introducing it. I mean, I'll give you an example. In London, where they have quite an active chemsex scene, we meet the needs for that clientele through the community pharmacies, and we will be doing the same in Herefordshire. So I suppose the answer will be, if there is a need from the service user group for IPED distribution and for paraphernalia associated with that, we will be looking to introduce that in some element. I hope that answers the question. So we've got a wide range of equipment for supply. Level 1 service through community pharmacies, but my understanding at the moment is it's more of a level 2, which is a bespoke service as well. Again, we need to engage with the service users, with the commissioners, with the LPC about that, and about how we match the actual provision to the need of the local service users. And what I'd ask you to do is encourage returns at every opportunity. But I hope this isn't new news. There's no 1-for-1 rule. While we encourage returns back, there certainly isn't a 1-in, 1-out rule, because that does impact distribution, and it impacts the harm reduction effect of NSPs. And waste collection will be arranged through Turning Point. So currently our service, our contractual service is arranging for bins to come out to you. And they should be with you prior to go live. So as I say, supplies are going to match current supplies at the moment, and Andrea's been doing moving heaven and earth to try and find out what your current stock is. And I know Hemang is also doing that through We Are With You as well. But as I say, that's not going to mean that that's going to be the stock that we run with for the next 6-12 months. There is going to be this process during this first 6 months of that needs assessment to see what is needed and what can be supplied through pharmacies. Obviously, there's a rundown of the current incumbent stock first, and then we move to the Vernicare stock, and Andrea is going to be talking about that in a moment. And Vernicare I've put visit, have contact with all NX pharmacies during the transition phase. So Andrea, I know, has been contacting you. Andrea is very active in getting out and meeting pharmacies, but obviously during the last year, that's not been possible. So I think that's going to be a wait and see in terms of how we come out of the roadmap. And the aim will be to review the supplies and packs during the early phase with the LPC and service user groups. And one thing that I'm keen to do, and again, we've been talking with certainly with the Hepatitis C Trust and with the LPCs, is looking about how we can get an active Hep C testing service in the NSPs in Herefordshire. Now, the advanced service came out in September last year. Obviously, they came out in September. It wasn't trumpeted, and it was at the time when you'd started your biggest vaccination program, flu vaccination program in history. So it's no surprise, and it's something that we've certainly not pushed because pharmacies have had other things on their plate. But as we move into the contract and as we move through Q2, Q3, I'd certainly be interested in working with the LPC and pharmacies delivering NSPs and the Hepatitis C Trust, who have said that peers would be more than happy to come in and support this programme under the advanced scheme to work out how we can do this and how we can have an active Hep C testing through our community pharmacies. Because one thing that I'm always aware of and I'm always promoting at national meetings is 75% of transactions for NSPs occur through pharmacies and 25% through specialist services. So 3 out of 4 of those exchanges, often those people will not come to the specialist services. They will use community pharmacies because they don't want to engage with the specialist service and maybe see people who they don't see. Although there's a number of factors that influence that. So that's a conversation I'm keen to have as well. So there's 5 pharmacies currently delivering NSP. There's 3 Boots, Kington Pharmacy, which I understand is one of the corporate bodies. I can't remember which one it is, sorry, and Westfield Walk, which is in
Kington's changed hands. It's an independent now.
Oh, has it? Okay then. Okay, lovely. And Westfield Walk, which is in Leominster. I said it right, Owen. Okay. So please, especially, if there's no pharmacies on that aren't offering needle exchange, I would encourage the LPC to have a conversation with their contractors around this as well, because I'm keen to look at the offer for NSP around the areas. So training and accreditation remains similar to, or in fact the same as supervised consumption. So again, it's the CPPE course. We recommend that you do, there's a number of e-learning courses. I'm mindful Andrew is on the call, but there's some very good ones from Exchange Supplies that have been developed by Jenny Scott from the University of Bath. I don't know if we've got any Bath graduates on here, but Jenny's created some excellent e-learning, and we'd encourage you to do that. It's not part of the mandatory training, but we'd certainly encourage you to look at it. Again, the fees for NSP remain the same that you're currently paying, so £2 per transaction, £75 quarterly payments. And as I say, we will be looking at various other incentives as we move through this. We're keen on take-home naloxone through particularly NX pharmacies, NSP pharmacies, and BBV testing, and potentially OST referrals through our website. And that's something that we can explore as well. You need the standard operating procedures include needle stick injury SOP, and we include an example of a needle stick injury SOP if you haven't got one within our locally agreed commission service agreement. And just a quick one, OST request for NSP. I've started to put this in because this is often a query that we get, and this is covered in our frequently asked questions as well. What I would say to you is if you get an NSP request for somebody who's on OST, we would expect you to supply, because the act of not supplying does not mean that client will not use, and it will increase their risk of sharing equipment and getting and increasing their risk of BBVs. What we would hope that you do is as you get the rapport with your clients, you're in a position to have a conversation with them about this. Whether their script is too low, whether they need further help, whether you can, encourage them to engage in the service, or even whether if they're requesting NSPs and you're providing BBV testing service, whether you can provide a test at the same time. So again, the transition from somebody who is not engaged in treatment, who's a heavy polysubstance user, injecting drug user, to abstinence is a long journey. And so, it's part of a process as they move through that. And as with supervised consumption, we're going to look at this in the first 6 months and decide how we move forward in terms of the products that are supplied and other services that can be provided through the pharmacies. Just a quick one. This again shows the impact of COVID-19 on NSPs. We're aware that certainly during the early months of COVID-19, NSP transactions. This is actually in 4 of our services, based on costs, decreased by between about 19% to 33%. So we saw a significant decrease as well. Again, from November, we started to see an increase after May. And then we had another decrease in November, and then we went into lockdown, and we're waiting for the January and February figures. But we did have an impact on that as well, and it's something for us to explore as we move forward about how COVID has affected needle and syringe suppliers and clients' engagement with NSP services. So in terms of any questions on NSPs?
There's nothing in the chat, but I don't know if there's anybody that's got any that they'd like to ask.
Nope, that's great.
Fantastic.
You know where we are if you need to anyway. So in terms of the CPPE, so you've got, if you haven't completed the CPPE before, you've got 3 months to complete it and do the declaration of competence. As I said, we won't be calling for them. You are professionals, and we expect you to do that yourself and manage that yourself, but it might be something that we do call upon in the future as part of our audit information. Annual training and engagement event with Turning Point. So we will provide at least an annual training event, and as I said, I've already talked with Fiona about during the first 6 months providing a harm reduction event, and also an event on OST and supervised consumption, which I've run previously. So I'll be working with Fiona looking at dates for that. None of these sessions will be mandatory. Again, as we were discussing at the start, pharmacies are very, very busy. GPs are very, very busy. And again, we'll explore the GP requirements as well. I didn't announce at the start, but I will be leaving my job as chief pharmacist and be clinical lead in Herefordshire. So again, I'm keen to look at how we engage with GPs as well, and their training events and their needs within the Herefordshire locality. The local contact at the moment is Hemang, and Hemang his email will be in the frequently asked questions document. So you currently, if you're on the call, you might be confused because you have been sending them back to Chloe, who's on the call tonight as well. But Hemang's now in a position as implementation manager from this week, so that will be going over to Hemang, and Hemang will be your contact for discussions around things like the local commission service agreement. And I expect as we move into April, if he's not got the expressions of interest back or the contracts back, he will be chasing you as well. Okay, lovely. Thank you very much. So I will now pass the floor over to Andrea.
Hello, good evening, everybody. What I'm going to just briefly talk to you about and give you a visual demonstration is the online ordering system. So initially, come the 1st of April, as Graham mentioned, you're going to be running out the current stock that you've got. So that's from the supplier is Orion Medical. Now, the kit that we're going to be supplying you, the specification of the needles, syringes, preparation spoons, etc., is the same. It's just a different brand, so the packaging is going to look different. For those of you that are dispensing the pharmacy packs, they currently come in a little brown bag, whereas the packs that we are going to be sending you are in a grey resealable bag. Now, because of the COVID restrictions, I won't be able to physically come and visit you. And as soon as the restrictions are lifted, I'll certainly make sure that I do that. So I'm hoping in June, which is, only round the corner. But between now and then, you'll have email correspondence from me, and some of you's on the call this evening. I may have already spoken to you because I certainly did a ring round back in February just to introduce myself and to let you know what's happening. So I'll be sending out a visual aid to you, which shows you all of the equipment, the injecting paraphernalia that's going to be available for you to dispense. and also the intended use for that as well as the product codes. So I'm just going to share my screen with you now, if that's okay. I'm going to show you what the online ordering system looks like.
Okay, I'm just going to stop sharing. It's over to you now, Andrea.
Right, great. Super. Just bear with me a moment. Fingers crossed this is going to work. Okay, can you guys see that?
Yep, perfectly, thank you.
Okay, so as you can see, the system's called the FCOM system. You will all be sent a username and password. So you will just enter your details in here like I'm doing. Now I'm a super user. So as I'm logging into this system, this has shown me all of the orders that have been, that I've put through on the system across the whole of the business, you know, since I was given my login details. But when it comes to you logging in, it'll take you into your dashboard. So when you first log in, everything across here is going to say 0. When you place an order, very simple, the order icon, create an order. Now, again, for me, because I'm a super user, I have to, you know, select, you know, what the accounts are. Whereas for you, for each pharmacy, it'll take you straight in to your site. This is a pharmacy for Turning Point in Leicester. As I say, for you guys, when you get your login details, it'll take you straight into your store, so you don't have to be worried about this part, because it's, you know, it's unique. Your login details are unique to your store. Selecting the items, it's as simple as add item, choosing the product, and remember what I'd mentioned earlier, I will be sending you through a visual aid which shows you exactly what the products are and what the product descriptions and the product codes are. You select the item that you want. So for example, these are blue 2ml 1-hit kits. It tells you here, the description is they come in a bag of 50. Now, if eventually in time you are going to be dispensing the 1-hit kits, if you only want 50 1-hit kits, you wouldn't ask for 50 up here, because what will end up happening is you'll end up getting 50 bags of 50. So you would just want one, and it's the same with the packs as well. So if it was a pack that you were going to be ordering, so for example, an intramuscular pack, it shows you here that 1 carton contains 50 packs. So if you want 50 packs, you wouldn't put 50 in here, because you would end up getting 50 big boxes with 50 packs in, and then it would be, you know, a bit of a carry on to get those all organized to be uplifted. So you select how many you want. If you want more items, you know, you just add more items to the order. You know, you just drop down the sharps containers, etc. on there, and then you wouldn't need to worry about putting in a purchase order number, because that isn't required. The courier, you'll not have that option. It'll automatically be on a next day or a 2-day. So the turnaround time from placing an order to the order actually being delivered to your store is usually between 48 and 72 hours. What I would suggest is, if you've got stock that's running low and you need a quick delivery, get the order in before 11 o'clock on a morning, because if you do that, the order will be picked and highly likely to be dispatched the same day. Any orders that are received after lunchtime are likely to be picked, but they won't be dispatched until the following day, which means you won't get them until the 3rd day, if that makes sense. But if you do have any urgent orders, you can always say, I've just put an order through FCOM, but we're running low on stock. Can you expedite that for us? And we can, you know, certainly do that for you. And that's basically it. Now, what I'm going to be doing is I'll be contacting everybody again, because I'm going to need your email addresses. And the reason I need your email addresses is to enable me to send all of the information out to you. So it'll be the web link with your username and password and the visual aid as well, and you'll have all my contact details. When you start using the online ordering system, as soon as you place an order, whatever email address that you give me, you will receive an automatic order confirmation into that email address. So we would suggest that you just give us a generic store email address for that. But that's basically it. Very, very simple online ordering system. You're not going to have, you know, hundreds of products to choose from. As Graham mentioned earlier, it's a bit of a bespoke product offering that you've got at the moment across Herefordshire. But from what I can gather, there's a you know, a couple of options of packs, and I think they're called emergency packs, as well as a limited number of pick and mix items. So the pick and mix for us would be, you know, a variety of needle heads, the syringe barrels that go with those, and the fixed syringes, and then the other paraphernalia, which would be your acidifiers, either Vitsi or citric acid, your preparation spoons that already have a filter with them, carrier bags maybe, and alcohol, prep wipes, and as well as a variety of different size sharps containers as well. So everything that you're currently supplying, you will continue to supply. It's just going to be a different brand. So the specification, as I say, of the product's the same. And what I'll do as well, a little bit nearer the time, when I contact you, when I send everything out to you, I'll have a discussion with you about how you can manage maybe some pushbacks from service users, because quite often when we're switching from one brand to another, they can say this product's not the same, it's not as good, or it's worse, or it's bending, it's barbing, or whatever. So I can give you some tips on how you can manage that. So there's nothing, I can absolutely guarantee there's nothing wrong with the injecting equipment that you're going to be giving out. It's just because it's a different brand, and with this, you know, with people who inject drugs, change can often be difficult for them. But we've done this millions of times before, and it, you know, it's absolutely manageable. And you know, they will get, you know, they will. It's highly unlikely that you're going to get complaints, but if you did, you know, I'll absolutely support you with that.
Andrea,
Okay.
thank you very much. I think one thing that we can say about pharmacies, and certainly from my experience, is sometimes you'll have clients that want a Tiva brand over an Accord brand. So you know, pharmacists are used to managing that, but your help would be greatly helpful. So just to clarify on a couple of points there, as Andrea said, you know, you won't have a massive list. The list will be restricted to what you're currently supplying. But as we have the conversation, if we feel that list needs to be shortened or it needs to be increased, even for, you know, for some pharmacies, there might be an iPad pharmacy or somewhere where iPad is needed more, we can do that. The final thing to say is, because we've talked previously about the system being automated, there is you know, we can have an automated stock control system. We've decided to do it manually at the moment because certainly in other areas it's created an issue at the start, and especially where we're trying to get a sense of what the supplies are needed, that if pharmacies don't put it in real time or the stocks change, we haven't got the right data, and you'll find that you'll be running out of stock very, very quickly. So if we get to the position where you're used to using the system and we get a set and we change the paraphernalia or supplies to a certain level, that's something we'll explore again. But we've taken a decision at the moment to try and make sure that you've got the stock and you've got control over that. That's great. Thank you, Andrea. Any questions for Andrea? She's always on the end of the phone. She always picks up, not like me. So so thank you. Right, okay, I'm just going to share my screen again. So I'm just going to pass you over to Stephen now. And again, Steve, if you want to go through this, and then if you want to take control of the screen to show the Neo 360 system, that'll be great. So over to you.
Thank you very much, Graham. I'm happy with your screen to stay up throughout. I don't want to punish anybody by going through death by database again. So my name's Steve Parkinson. I'm from Neo 360, and we've been working with Turning Point for over 6 years now, providing data collection solutions across a whole kind of theatre of harm reduction initiatives and services. We do GP shared care, take home naloxone, BBV testing and vaccinations, alcohol audits. But here in Herefordshire, we'll be providing the database and data collection system for the NSP, the needle exchange, and for supervised consumption. And it's basically just a database which is web-based, where you can log on to and log all the transactions. It's a single platform, so we've only got the 2 modules on there. It's totally secure. It's designed to be a real-time system, so we are expecting to the pharmacists or the site managers to put information onto the system in real time or as close to real time as possible. As I say, it's totally secure. It's backed up every 24 hours. We're not going to lose any information. It's got an SSL certificate. Everything is username and password driven. So no matter who you are, you'll be given a unique username and password. And where you log on will define, your username and password will define where you log on into the system. So the site manager or the pharmacist who's doing a supervised consumption transaction or needle exchange will be able to do that activity, but also view their staff. They'll be able to see the financial information, and they do some basic reporting on their site only. They can also devolve some power down to other members of staff, so they can also do transactions on their behalf. And they'll have lesser functions, or they can give them the same functions. So perhaps somebody who does a needle exchange transaction with a client may not need to see the financial information, so that will be restricted on their kind of user profile. So as I say, we're doing needle exchange and supervised consumption, and the way that it works is we log on onto the system. You can leave the system logged in all day. We have a client who comes in. We can enter the gender of that client and an attributor, ideally being initials and date of birth of that client. Now, if the client is unwilling to give the date of birth in a whole format, then as long as they give that year, or if they want to be Mickey Mouse, just make sure they're consistently Mickey Mouse and consistently give the year of birth, so we can do some basic reporting on demographics, age and gender, etc. If the client, as sometimes they are in a rush and they need to get a taxi and they're unwilling to give any information, then we have a total anonymized button which you can press to be able to do a transaction. So the client comes in, we take their initials and date of birth, we take the gender, they bring back hopefully some returns in the shape of a sharps bin. We can enter that sharps bin as being returned. We also got the facility to itemize what items of paraphernalia or packs are going back out to that client. We can then click on save, and that is a transaction complete. Once a client has been through a pharmacy or through the fixed-based location, it goes directly into the transaction page each time. However, on the initial visit, there is a few questions that we ask, which allows Turning Point to collect some kind of information on demographics and age and gender, and other items such as housing status, the substance of use, and how often they use that substance. This provides reports to make them better informed so they can provide a better service and provide better equipment through the pharmacies. We also have a referral tool on the needle exchange, which is the ability for pharmacists or pharmacists to ask the client to make an intervention. Do they want to go and see somebody at Turning Point? And we have an automated system where the pharmacist can take some basic contact details, press a button, and then that kind of intervention gets sent to a Turning Point NHS email address. They pick it up. They can then contact the client and they'll hopefully bring them into service. So that's the needle exchange, hopefully explained. Supervised consumption, entering the details is a little bit simpler. You're asked the gender of the client, and this time we will know the initials and date of birth from the script that they've got. As soon as you log in and put those details in, you'll be presented with a calendar view for a particular month, the month that you're actually working in, and you've got the options to enter what opiate replacement was actually supervised, so whether it's methadone or Respironol or buprenorphine, and you check the box as you go along on each day. If the client is taking home, we have an option to check the box for take home. If the client misses a dose, we've got the option, obviously, to click that. So we can get a full kind of visual dashboard of each client throughout the month, from historical months as well. Again, I want to emphasise that it's a real-time system, or as close to real-time as possible. And there are several reasons for that. Graham mentioned that we may be moving, or there is the opportunity to move to a fully automated stock control element of the NSP. And in that, we'll need to ensure that transactions are put on in real time so that we get a proper count of actually what's in stock. The benefit of that with pharmacies, it will save you time in making sending an email or contacting Andrea through the internet to place an order, because hopefully all orders will be fully automated going forward. And again, one of the things of being a real-time system, you can see your monthly activity in real time of actually what you've done. So you can see how many NSP exchanges you've done, how many supervised consumptions that you've done, and then that way you can keep an eye on what you've entered, and what you've entered by the end of the month, hopefully be what you get paid for providing. On the supervised consumption front, we also have key workers or harm reduction staff or nurses who also have access to the system, and they like to see or be able to see their clients and whether they've picked up or whether they've missed a dose, or what the kind of the amount of times that they turn up in a particular month, so they can make an intervention. Perhaps if somebody's missed 2 doses, they can then contact the client prior to them missing the 3rd dose and stopping the script. And also, if you're putting the entries on, you put them in real time, you can see what you're going to get paid. Everything's done on a monthly basis, so that we can better pay the pharmacies. So you can make budgets for what you're going to receive in payments. All activity is logged within the month that you do the transaction. We also do the financial element of the Neo 360 system, so we can pay you through the activity that you do. So we ask you to put the transactions on within that month. We provide a period of grace to the 7th of the following month for you to do any retrospective transactions, and then we can press the button. The file becomes read-only. We can then send a consolidated report to the service manager at Turning Point. They then validate the claim. They provide a purchase order to Neo 360. We then invoice Turning Point. Turning Point then pay us the consolidated amount, and we then distribute the payments within 2 or 3 days tops, working days from receiving that payment, and we distribute all the payments to pharmacy, so that you'll get paid accurately. We'll send a remittance email of what it is that you've been paid to your nominated email account for the accounts, so that you can get regular payments, accurate payments, and get them in a timely manner. I just want to mention a bit more about the benefits to the pharmacy of using the Neo 360 system. Obviously, there's the time-saving elements of not producing things on paper, or it's going to be no submission. When you log your transactions on the 7th of the following month, we get to see all the activity that you've done, so there's no need for you to submit a claim. All the activity is then logged, it goes into the database. We can then provide payments from that. We can provide the auto stock in future, which will save time again. And as I say, you will be paid on a regular basis because everything's budgeted on a monthly kind of timescale. So what's going to happen between now and the 1st of April? I'm going to hopefully contact you, or Himang Patel will contact you to try and get your email address, so I can then send you instructions as to how to use the system, and give you the URL to access the Neo 360 portal. I'll send you a username and password. The instructions that I send are fully comprehensive. It's a very basic system, dead easy to use. And all we're doing is collecting basic information and to facilitate the reporting for Turning Point, and the trade-off is that you get the payments for providing that service. I'll be providing email support as standard, as is telephone support, and your first line of contact could be Himang, or indeed if you need to call me, you can drop us an email or give us a phone call. And then as the COVID restrictions and we follow the roadmap out of the lockdown, I'll be attending the sites, your pharmacies, and I can provide demonstrations or a bit of training face to face. In the meantime, I can also do it online. So if you're struggling on the instructions I provide, just drop me a line. I can then give you a web-based demonstration over the phone as well, and get you up and running. So to recap, it's a web-based system designed to collect needle exchange and supervised consumption activity, to provide some basic data for Turning Point to use to give better service user outcomes. The trade-off is that you can get paid from it. There's no need to submit any claims. You'll be paid regular on a monthly basis in a timely and easily reconciled manner. We're hoping to introduce automated stock control at a later date, and you'll have the full support of both Himang, the implementation manager, and myself directly from Neo 360, and also the staff that work at Neo 360. So that's my presentation. If anybody's got any questions, please feel free to ask.
Okay, over to you, Owen, Catherine, Chloe. Is there any questions coming in, or?
No, there's no comments at the minute.
Okay. Just for information as well, the frequently asked questions document that I'll send out will have all contact details in for Steve and for Himang. And if the URL hasn't changed for the video demonstrations as well, Steve, we've got that in from the previous implementation we've had. So you'll be able to access video instructions as well on that. Lovely. Thank you very much. So next steps. So if you haven't returned your locally commissioned service agreement yet, please do so, but send it to Himang Patel now, because Himang has actually taken over as implementation manager, and he's working with Chloe, and Chloe will be sending the ones that she has over to him, so we can start building up our database of returned locally commissioned service agreements. What you need to know is that if we haven't got those on the 1st of April, we're not going to pull the funding. We're not going to withdraw you from the service. We want you to be engaged with us, but please get them in as soon as we can, because we don't want to be chasing you for them as well. So watch out for the frequently asked questions document, which will be coming out soon. I'm just finishing that off hopefully tomorrow, and with Fiona's cooperation, hopefully we can get it to Fiona for distribution to pharmacies, and perhaps the LPC can also host it on their substance misuse section site. Please discuss this presentation with your team. If there's a recording of it, so again, we'll share the recording details with Fiona. We'll send that out, and we'll also put the recording details, the link with that, into the frequently asked questions for you as well. And look out for further training events, which we will be delivering in 2021. As a final thing, I'd just like to say, I'm really excited about coming up to Herefordshire and working in the service and delivering clinical services in Herefordshire. As I say, I'm going to be clinical lead up there. I am a prescriber myself, and I've carried a prescribing qualification since 2007. And primary care is a very special area of mine, so I'm really looking forward to working with all the pharmacies and all the GPs and seeing what we can do together to to deliver really efficient services to our clients in Herefordshire. And that's it. So any further questions before before we finish for the night? You all know where we are if you need to get in touch.
Brilliant. And thanks everyone for making the time to come and join us this evening.
Thank you. Yeah, I've just got one question, Owen. Are new SLA going to be sent, or do you mean the last one that WAWY sent to us? The SLAs have been sent to you already via the LPC. So we sent an expression of interest document out to pharmacies, and that included the SLA documents. So if you haven't got that or haven't got access to that, please contact Hemang or Chloe, and we'll get them back out to you again. Okay, and I think that's it. So before we go, I'd like to say thank you for everyone for attending. Thank you for Stephen and Andrea for coming along. Thank you for Fiona for being for working with us so closely over the last year, I think. And hopefully, you know, we'll have some bumps in the road, but hopefully we can navigate those and really deliver effective services in the Herefordshire area. And I will let you all leave now and watch Taskmaster.